here. This is, let's see, what is today?
Today's the 10th.
March the 10th, 2020. Has anybody heard anything about this thing called the coronavirus? I'm guessing that people probably have heard about this. I don't know how you could miss it. I did put out an article in the open line this last week that talked a little bit about coronavirus and some of the, what I was talking about in my article was ways to help people with disabilities follow some of the precautions that the CDC has put out. So, you know, some of these things are very basic and things we ought to be doing all the time anyway, but they included things like, first of all, I think it's a good idea with people with disabilities or anybody to just talk a little bit about these health issues. I'm sure, you know, people have talked about different things like, shaking of hands, maybe best replaced with a fist bump, right? Touching of the face should be avoided, although I will have to concede that one is very, very difficult to accomplish. But you can combat that somewhat by making sure that you wash your hands frequently. Probably most everybody has heard about doing the ABCs, like washing your hands for 20 seconds is what you're basically shooting for. But if you say the ABCs, A, B, C, D, E, F, G, and go through the whole alphabet and make sure you go in between your fingers and do your fingernails, the cuticles, and your thumbs. Don't forget about your thumbs, all of those things. Then you can wash your hands well. And if you do that frequently, then you are going to do a lot to really avoid transmission of any kind of virus. The other really important thing is doing proper coughing and sneezing etiquette, as they call it. It's not really etiquette, it's health. What we're talking about is not etiquette, it's health. But sneezing into your elbow or coughing into your elbow or using a tissue, make sure you throw the tissue away afterwards. Don't hold on to it. Don't stick it in your pocket. Don't put it somewhere where you're likely to grab it again. Throw it away. And the other aspect of this is that if you are a person who is sick or a person with some kind of a respiratory disease, CDC is saying basically you should avoid going into crowded congregate settings. It's better to avoid those types of settings. Now, I'm not giving guidance or saying you should force people to do these things. I'm just saying these are different things that are considered important by the CDC and that they're the guidance that they're giving. The other aspect of this, I also gave a little bit of guidance on how you could help people with disabilities do it. So I was thinking about when you do those ABCs, making a big deal out of it, you know, as you're washing your hands. And by the way, Trey just reminded me that you can also use an alcohol-based hand sanitizer. That the guidance is that has to be 60% alcohol to be effective. So I don't know, you might want to check the alcohol content on what you just gave me there. But making a big deal out of washing your hands, maybe making a little bit of a game out of it, making, helping the person with disabilities see this as fun and maybe would join in and maybe a contest on who can wash their hands the longest. I don't know, those kinds of things. You could also think about potentially, sort of make a big deal out of sneezing into your elbow several times a day. Have you ever been to Disney World where I couldn't remember where this was at Disney World, but they've got a mountain and it'll go choo, and then it'll blow out the top of the mountain. And I thought that would be a kind of a fun game to play several times a day. Make a big deal of, I'm about to sneeze, and then sneeze in your elbow or sneeze into a tissue. Make sure you throw the tissue away afterward. Very, very important. So you can just get creative with these things. I think it's a great time, perfect time to be teaching people better personal hygiene and better care for themselves. These are all things that we should do on an ongoing basis. So I just wanted to make mention of those before we launch into our topic of the day. We've got a great guest here with us again today. It's going to be Mr. Johnny Payne. He's been a guest with us before, but he has changed employers since the last time he was here and has a new program that he has started, and I'm going to let him tell us a little bit more about that in a moment. But before we get into all that, Johnny, you want to take a moment and introduce yourself?
Hey, what's going on? Can y'all hear us okay?
We can hear you great.
Brilliant. Okay, yeah, we tried the computer earlier and it did not work out. So, okay, so I'm Johnny Payne. I'm here with my friend Holly Brandt, and so we're both here with Orange Grove Center in Chattanooga.
Okay.
So I'll maybe let Holly introduce herself first.
Okay.
I'm currently a special ed teacher for Orange Grove. I'm also a BCABA and actually got and kind of started the getting the IOP program off the ground here at Orange Grove.
Intensive outpatient program.
Yes.
Is that what you're saying? Yeah, okay. Wow, okay. That's fantastic. How long have you been with Orange Grove?
About a year and a half.
Year and a half, okay. And you were a teacher prior to this, or are you still a teacher?
Actually, I was a special ed teacher years and years ago, but maintained my certification. I worked as a behavior analyst for a private company out of South Carolina for about 9-10 years.
I see. All right. Now, one of the things we noticed on the outset, because your video was up, was that you were touching your face at that moment.
I know, classic coronavirus, don't do that.
Right. But is there any interesting facts you can tell us about yourself that other people may not know? Now, keep in mind TMI. We don't want too much information here, but any interesting hobbies or anything like that you're into?
She's never worked out a day in her life.
I obsessively work out, so no,
okay.
I obsessively do. No, I'm really not that interesting. I've got 4 kids at home, just work and get day-to-day life.
That's pretty distinctive to have 4 kids, and that probably keeps you working out quite a bit.
Yeah.
Obsessively. I'll brag on Holly. I've got big shoes to fill here because her work on the program before it was handed to me is scrupulous, to say the least. And she's such a great detailed person and has done a lot of great behavioral work with some of our past clients. She's wonderful. So
I'm anxious to hear about this program. I will say that when I had kids, I developed an exercise routine of just trying to keep up with my kids all day and all the things they were doing. And man, that was the best exercise I ever got when I did that. Okay, so Johnny, that's great. And tell us about you and your new position in your profession.
Okay, so I'm Johnny Payne. Last time I talked with you guys, I was a rehabilitation therapist at Moccasin Bend Mental Health Institute, and so I did a lot of group-based and one-on-one functional skills training, CBT work, things like this with folks with a severe persistent mental illness. Now here at Orange Grove, I coordinate our our mental health programs. So the first of which is our IOP, our intensive outpatient program. The next one that we'll work to develop will be a psychosocial program that will have components of contribution, of interpersonal relationships, and just integration into the community. So that is a few months out before we work on developing that, but we are working to build up our client base for this IOP program in one section, and then we'll probably start moving to 2 sections. Interestingly, we will have 2 different sort of levels of functioning in the program. One will be those who are generally verbal and are expressive verbally. The second group that we will likely take on will be largely verbal persons. And so that'll be an experiment that we try here in a few months.
Okay, that sounds cool. Now, before I'll let you go too far into your program.
Yeah.
Remind us of a personal fact that we might find interesting.
Oh, goodness. I want to joke and say, like Holly, I'm not an interesting person. Holly's a very interesting person. I really enjoy outdoor sports, kayaking, fly fishing, mountain biking, climbing. Really enjoyed the outdoors, and Chattanooga, Tennessee is a great spot to do that.
Oh my gosh, yes.
Shameless plug for Chattanooga. Come on down, y'all. But I've got a wonderful 2-year-old at home and a wonderful wife that I really like spending time with, getting into all sorts of misadventures. So that's me.
Does she say the same thing?
I don't know. You'll have to ask her that.
Okay.
I won't speak for her.
All right. Well,
presentation.
So tell us a little bit about this. You started to tell us a little bit about your program, but let's go into a little more detail. Tell us what's going on down there at Orange Grove. This is a great program that you put together, sounds like.
Well, yeah, thanks. And again, big plug to Holly, Amy Jo Shamans, and some other folks who had a hand in putting the very beginnings of this together. So first of all, an IOP. For those who are maybe on the call who are not familiar with IOP, there may be one or two out there. IOP stands for Intensive Outpatient Program. It's a pretty regularly recognized service that sort of sits in between intensive inpatient care, a person who would be at a facility overnight for multiple days, receiving treatment for all sorts of things, and actual community independence or just being in the community. So this is sort of the go-between from an inpatient program to just community participation. So IOPs serve all sorts of different purposes, from eating disorders to substance abuse, all kinds of things. But this program serves mental health, emotional regulation, and things like this. But specifically with those who have a co-occurring intellectual or developmental disability. So most of our people who are coming into our program have generally an autism spectrum diagnosis. Some have a intellectual disability. But from what we're seeing from some of the folks that Holly served previously, and some of our first round people who are going to be in the program, they also have an anxiety disorder, bipolar disorder, schizophrenia, things like this. So there's a strong co-occurrence with autism spectrum disorders and anxiety disorders. But I'm wondering if some of are all of the people that you're serving with autism spectrum disorders, are they people who also have an intellectual disability, or are they people with just an autism spectrum disorder and no intellectual disability? I think most of them, yeah. I think of one of our people in particular that we'll talk about here in just a little bit doesn't necessarily have an intellectual disability. Does our friend eventually?
I don't think he does have a diagnosed one.
Yeah, the guy that we'll talk about here in just a little bit, I don't think that he has an intellectual disability. Right. He just has the features of autism spectrum disorder that affect executive functioning, that represent behavioral challenges for him. So, interestingly, across the board, 40% of folks with intellectual developmental disorders also have a co-occurring SMI. And oftentimes, as we've talked about on the CCN here, Folks don't know how to talk really well with each other from these sort of two different worlds of mental health world versus IDD services world, and so a lot of agencies, a lot of service providers don't know how to treat a person who has an IDD with a co-occurring SMI. And so we see this challenge, especially behaviorally, all the time, I think, in Orange Grove, and so it made sense, so much sense, to try to provide mental health services for our people here.
Yeah, it makes a ton of sense, and so yeah, the statistic that you stated there, I mean, you see different estimates, but yeah, a lot of people with IDD have a co-occurring mental health disorder that gets completely overlooked because everybody's just looking at the fact that they have ID or they have a developmental disability and not really considering the other co-occurring diagnoses.
Sure. So I've kind of got this broken down into little bits of kind of sections, so I'll just go ahead and tell you, we just kind of introduced the IOP, what it is. The next thing I'd like to talk about is what is DBTSS, the model we're using, and then a couple more details about how do we administer our program, and then we'd like to talk about one of our people named let's call him Tony, who is one of our participants.
Okay, so DBSS should be familiar to a lot of our audience out here because we've talked about the skill system. Am I hitting the right note there, Johnny?
You're singing the right tune, Bruce.
All right, yeah, Julie Brown's skill system, is that correct?
That's right, yeah, Julie Brown's DBTSS, so that's a dialect, yeah.
All right, so well, go ahead and tell us more about that. How are you implementing that?
Okay, yeah, so Julie actually talked on the network a little while back. So her deal is based off of DBT, which is a form of cognitive behavioral therapy. What DBT is working to do is to establish an ability to interact with mindfulness, emotional regulation, stress, coping mechanisms, and interpersonal relationships within their people. But I actually remember you talked about this a while back, Bruce, that a lot of the people in our service, the folks that we serve with IDD, are often set up to regulate emotions externally. They have people who are telling them, hey, calm down, or hey, you're okay, or whatever it may be. And so a lot of our folks, when they've been interacting with our services for a long time, and the whole service continuum, they don't learn or practice internal regulation of their own emotions. And right. So they rely on other people to regulate their emotions for them. And so what DBT does is helps people internally regulate their emotions and set them up with skills. So the DBTSS by Julie Brown skill system breaks down what is kind of a difficult to approach for the lay person kind of a model to administer. And so it breaks down the whole DBT model into 9 skills and some frameworks on how to administer those skills. So it makes it way more user-friendly. Yeah. So that's what our whole model is based off of. It, the nuts and bolts of how we're administering it, we have a space here at Orange Grove where folks that we have, at least first, hand-selected for our program from the other services that we provide. They come to our space, and we spend time with them from 9 o'clock to 12 o'clock, so 3 hours, okay. Monday, Wednesday, and Friday. And so, during that time, we are doing instruction on what is this particular skill or aspect of the skill. We spend time practicing it, and we also spend time reinforcing other parts of the program, there's a part of DBTSS called New Me activities, and so we work to have a bunch of New Me activities that are available at our fingertips within our space, and we have space in our day to pull that out and practice that either as a group or individually to be familiar with and practice that and remove barriers from access to those kinds of goal-oriented activities.
Yeah, I was just going to mention the New Me skill is one of the skills I like the most. And in fact, I don't know if, I know I've mentioned this before that I do horse experiences out at my property. And I created a trail ride that had different skills people would learn from Julie's skill system. And the name of the trail was the New Mexico Trail.
That's
that
cool.
was supposed to evoke a little bit of response. Yeah, well, Trey could have laughed for me over here, but he didn't. But yeah, the New Mexico Trail Ride, because what the idea was, you're going to create a new me by going on this trail ride and doing something different, doing activity. So, but that's kind of what you're talking about.
Yeah, absolutely. I mean, what I really like is that in the beginning of our program and in a lot of what Julie Round talks about is first working to establish what are the goals that this person has, super individualized for them, and working towards those goals. So a New Me activity is an activity that lines up with that person's goals. And so who do I want to be? What sort of living situation do I want to be in? What is an activity that's going to help line up with that goal? Is sort of that New Me. So I think the other part that is important about the DBTSS that Julie Brown recommends and that we're doing here is working to train the staff of the persons that we support. So while in our program, we actually do that at the same time that we're working with the persons. So while the persons who may be sitting in group with us, we have a little training space right off where those staff are going to be trained on the same skills that the supported person is working on at that same time. So say someone may be working on clear picture, which is one of the DBTSS skills. At that same moment, the staff person is going to be trained on clear picture. It's going to help the interaction between the staff and the supported person be able to be calm, rational, and respectful to each other. But it's also going to help the staff reinforce that skill with the person in the community, in the group home, or wherever they may be. So that's pretty important to us. And I think we should say that we do this in a group setting, Monday, Wednesday, Friday, 9 to 12, but we'll also be spending one-on-one time with our participants, sort of generalizing what we have been working on in the classroom, so to speak, in their actual group home. So it may be that we go meet with them in their group home and we say, hey, remember clear picture, show me a space in your house physically that you have felt anxious recently. Let's go practice clear picture at that spot together right now. Wow. And we work to try to translate that directly and as generalized as possible into their environment.
Oh, I love that generalization aspect of that, because that is one of the hardest things to do, is to get people to take those skills and do them in their own setting like that. And I think that's a very creative way of doing that. Trey was really impressed with your statement about training the staff. And that seems to be a real important component, because that's going to aid in generalization too, if you have the staff prepared to kind of reinforce these skills and talk about them in daily life. So has that part worked out pretty well? How's that panned out?
Well, one of the staff actually went with Holly, actually the staff person of the supported person we'll talk about here in just a minute, went to Julie Brown's training whenever she was here in town recently. And so he's been able to, I think, have a much better relationship with our friend named Tony, let's say, than I think that he would have been anyways. But we will be starting those training sessions again whenever we start working with our new group of clients here in the next couple of weeks.
Okay, wow. So he was a direct support professional that went to that training?
Yes.
Right? Yeah, wow, cool.
Well, yeah, technically Holly's reminding to a house manager.
Yeah.
House manager, okay, well.
Yeah, he actually lives with him. He is the house manager of the residential house, so.
Okay, very good.
Yep. And now I think we could probably talk about our friend Tony.
Which is a pseudonym.
Which is a pseudonym. His name is not actually Tony. I don't think I've ever served a patient or supported a person named Tony. So that is as vague as I can possibly get.
As you come up with.
Yeah.
Yeah. All right. So yeah, tell us about him.
Well, I'm going to hand this off to the master here, Holly, who's done much more work with him than I have, and she's not been his BA directly. Actually, my office mate next door has been his BA for a while, but he's not available right now. But I think Holly could say it a lot better than I could.
Okay, excellent.
So he came to us directly from an inpatient program. Yeah, so he was in an inpatient program and came to our residential setting. Gosh, it's probably been, I don't know, maybe about 9 or 10 months now. And he was immediately a candidate when we were starting and just kind of opening the doors to the IOP and just even thinking about clientele or individuals that would be a good fit for it. Originally, when he was very hesitant to come, in fact, refused. I guess I wasn't there when it was coming time for him to come, but the wording actually IOP, it's time for the IOP, was used with him. He refused to come. There was some form of history there where I don't know where that terminology came from. He felt like he was in trouble in coming. And so originally the first things that I had to do with him was really just pair the environment and myself with reinforcement. We dropped everything about the IOP, although technically he was involved in a session. From his perspective, he was just coming to hang out with me for a while. And I spent probably about a month getting him comfortable in the space and letting him direct a lot of the activities that we did, just to get him comfortable coming.
Do you find that that's like something that's good to do with people with disability? I find a lot of times if you try to sit down and have like something that's called a formal therapy session, that it sometimes falls a little bit flat and becomes real difficult to communicate. But if you can kind of couch it in a little bit different terms, that you're able to get through a lot better. I don't know. Do you find that to be true?
Absolutely. I mean, you've got to develop some form of rapport. And, I mean, without any level of rapport or comfort level, you're not going to get very far at any point. I think that's probably one of the most important things that you have to do in the beginning.
That's true with a typical population, but it's even more true, I think, with the
Absolutely. Especially with somebody with the history that he has. He's got a pretty significant history of physical aggression, property destruction. That is what got him into, he's a very large individual also, so he's physically intimidating. And so that is what got him into the inpatient program to begin with. So, you know, he is, in some ways, he demonstrates a lot of control about his emotions, but, you know, again, and knowing that he does have, you know, a mental health diagnosis and amongst many other diagnoses, I mean, there are many ways that he isn't in control of it.
Yeah, I was just going to mention, this is one of the interesting things I find about this group of people is that they are often really doing a lot to try to manage their situation. It just becomes really, really difficult for them at varying points in time. and it sort of starts to break through.
Yeah, no, it was interesting. I did a session with our friend Tony yesterday, and we were talking about measuring emotions and things like this, and he says, yeah, when that thing happens, I feel angry, and he like was really expressive with his body, like big angry, like really big angry, and he said, I don't want to be angry. I don't want to be angry. I don't want to throw a TV at my house manager. And later, afterwards, often really regrets the thing that he did.
Yeah, he's very sorry after the event, but so we spent a long time just developing just a comfort level with me in the space, and we're finally able to move on to, one of the probably primary things that I focused on with him after that is the development of like new me activities. It was honestly just trial and error. Every time I was with him, we would try new activities. He wants to talk about his feelings, and he wants to kind of have a back and forth with you. His language is significantly below, of course, his age level. So just sitting there and talking with him for an hour is very difficult because he's very repetitive in what he says. You know, his phrasing is a little broken. And so one of the things that I started was I had a puzzle out, and I would just sit and work on the puzzle, and he would come over and just start. He enjoyed doing the puzzle. And we could kind of talk while we were also engaged in another activity, but really focusing on developing all these new me activities, and actually had a little packet that he would carry around with him of stuff, like he enjoyed coloring, sorting cards, and got to the point that we could, you know, Julie uses a lot of kind of the terminology and on-track actions, on-track thinking, you know, stuff like that. With him, I didn't feel like he was totally ready for some of that terminology, and so we were using things as basic as, you know, making good choices and bad choices. Bad choices are going to get you here, good choices are going to get you here. Instead of making a bad choice, these are some of our good choices that we could make, meaning the new me activities. And he really made a lot of significant progress in terms of identifying when he was starting to feel anxious and moving right into doing a new me activity, even on his own without a lot of prompting from staff for quite a while. He made a lot of significant progress with that. And in fact, he and I were doing something random. I was helping somebody with something one day, and he came and helped. He was with me, and he made the comment. He goes, this could be a new me activity. Wow. Just kind of trying to get the point across that this was something he enjoyed and something that he identified as relatively calming for him.
That's like, boom, gold.
Yeah, right, yeah, it was great.
That's, as a therapist or as a behavior analyst, that is like, okay, you just repeated back to me the thing that I was looking for, so I know we're making...
Can I get that in writing, please?
Right.
Yeah.
You know, some of the challenges that he has, unfortunately, there is a little bit of, there's been some staffing, you know, Johnny just talked about like the staff training and what an important component that is. His house manager is actually the one that went to the training with me. But there's other, you know, there's other staffing levels, and unfortunately in this field, there's somewhat of high turnover rates for DSPs and such, especially like for your second and third shift. So there's been a good bit of turnover in that house. It's a hard house to work in, not just with this individual, but there's another individual that's pretty difficult in that house as well. And so, you know, some of the staff training and consistency across the board, of course, wasn't where we wanted it. And we definitely saw that within him and his reactions towards different staff that was there, and subs and stuff that had to bring in. And so that's definitely something that needed to improve for him. That's something that we as Orange Grove needed to improve. Another one big barrier that he has is he wants to go home. He wants to live back at home. That is just not an option for him. His family has stated to us they don't want him to come live back home. He is going to be in a residential setting for the rest of his life. But the problem is they're not expressing that to him. So he feels like he wants to work. There's something that he's doing or needs to do, or something that he can achieve to get to go live at home. And that is a very big barrier. He very much enjoys talking to his mother. She's inconsistent about talking to him and devoting like set periods of time that she talks to him, which then triggers certain behaviors with him. And so, you're kind of knocking your foot and your head against the wall a little bit with that because, in some respect, it's not fair to him to kind of have this goal that he's just never going to reach.
So is part of the work with the mom and the family on trying to help them be more candid with him, or is that what, or is that part of what you're doing? Okay, yeah.
It is part of what we're doing in combination with the MCO and just, obviously his entire team.
Right.
Was just trying to get a straight answer for her. Originally, she wasn't very straight with even us about it. If it's not an option for him to go home, then we just need to tell him that and move on and help him get through the emotions that he's going to feel about understanding and trying to get him to understand that information, but kind of constantly dangling it as a carrot in front of him is not the best thing. But it's a significant challenge that he's having to go through, for somebody with a mental health disorder along with, other developmental disorders. That's very hard to understand and a hard concept when when he feels like there's this unreachable goal.
And where you find yourself confused because people are not speaking with the same voice to you about things. I think you're onto something there. And the only other thing I might mention there is that, it seems like families a lot of times have a lot of reasons. I mean, of course, at the basis of it, they just feel empathy for their person, and it's hard for them to want to step over and deliver a hard truth sometimes, but failing to do that actually creates more problems sometimes than it solves.
Right. Yeah, and I kind of mentioned where he has demonstrated at times being very in control of his emotions and behaviors to the extent of he is almost. He goes back and forth about not wanting to live at Orange Grove. He wants to go back to his residential center, or he wants to go home. He is trying in any way that he can figure out, in some ways, what can I do to get myself out of this situation, either because previously when he was dismissed, when he was out of the residential center, he did come directly to us that he was allowed to go home for a certain amount of time. And he's made that comment that if I can get back there, I can go home. And I think he's made that kind of chain of he has that chain of events in his head. That if I can get back to, if I can do something to get out of here, I can get back there, which is going to ultimately get me back home.
And I even wonder.
It's a big barrier. It's hard for him.
I even wonder, here recently, our friend had an incident that he had a behavioral incident yesterday, in fact, where there was a new roommate that was introduced to the house, which presented for him likely an anxious situation, and so he had this behavioral incident. And I could imagine him thinking to himself, I don't like this situation. I want to get out of here. How do I get out of here? I go back to this inpatient psych, and then I get brought back home. How do I do that? I have a big behavior, a big negative behavior. And so I think Holly's on it. Like if we could get a consistent page on what is the pathway for less restriction for him, and make sure that we're consistent in how we communicate that. That may not be an option for him whenever he considers, I don't like this place. So I think we need to work to create a clear pathway for him.
Yeah, when we're sitting here saying, he'll have a conversation with his mom about what do I need to come home, and one of the things she told him was he had to be able to go make friends. Well, he's nowhere near at his current functioning level to where that is something that he is even ready for, prepared for, anything. And so for him, he kind of turns around to us. He's like, okay, I need to go make friends. Well, you're, then on our standpoint, we're like, but you're so, not that we have said this to him directly, but he's so far from that. That's just, he needs to be able to just function from a day-to-day basis within his house and within his current environment before he's out in the community making friends. But for him, we're a barrier to that. So, on one end, he's made a lot of progress in some ways, in terms of development of new me activities, but he, you know, he's getting a little bit of different input from, you know, his family side and then, of course, our side, which inhibits our ability to make a ton of progress with him as well.
Yeah.
Right. So he wants friendships. Is that an accurate statement?
He wants friendships with people that he will say his house manager, again, I mean, he's got a developmental disability. He will say his house manager is his best friend. They spend a lot of time together. You know, I mean, they're with each other 90% of the day. He helps the house manager do things to earn money. So, of course, you know, the house manager has paired himself very well with reinforcement and from that aspect because, you know, this individual likes to go purchase things on his own and has a list of things that he wants to get. So that's very enjoyable for him to go participate in some things that he can earn some money. He just enjoys kind of that one-on-one attention because the other individuals that are at that house are at school all day. And so he wants adult attention, which is very, you know, of course, common from with individuals on the spectrum also. And he enjoys adult friendships. People his age, unless they're benefiting him directly in some way, you know, just the pure joy of having a friend, no, not from that aspect.
Yeah, and it's interesting because, you know, I look at our friend here, and the situation that he's in, is it conducive for friendships, period, with peers? And it's really not so much because the people who he physically lives with are completely nonverbal.
Yes,
They're gestural. They can gesture with and express with gesture, but largely it's just very difficult to communicate. And anyways,
his primary reason for wanting friends is because that was given to him as a goal to get home.
I see.
Right.
I see. Well, the only reason I brought it up is because I've noticed this with a lot of people with autism spectrum disorder that they still desire friendship even though they might not be that good at it.
Yes.
You know, because you have to have the social skills to make it work. And so, you know, it's a way of motivating to some degree learning of some of those things that can help with that if you bring those things into the picture. So, and remind me how old he is.
We could give an age range.
He was born in 85.
85. That's quick math. That's 35, right? Somewhere in that.
Yeah.
Okay. Yeah.
Yeah.
No, I'm sorry. He's 25. He was born in 95.
Yeah.
Okay. Okay. He's still a young man.
Yeah. Yeah. And honestly, a conversation for another time. I think it's interesting to consider a lot of folks on the spectrum and their relationship to online relationships, electronic relationships.
Yeah.
But that's for another time.
Yeah, I was just thinking about this because on Saturday Night Live not this past week, the week before, that they were talking about baby boomer dads. That baby boomer dads didn't have any friends, and then I started thinking, well, that's me. Basically, I was born in '62, so but it doesn't mean that we're not desirous of friendships, though. We just don't have them. So that's I think that's just worthy of some consideration. Is trying to figure out how you can help somebody connect. And I do get what you're saying, that there are a lot of skills he needs to learn to maybe make that work. But maybe even thinking more about what you're talking about, Johnny, is something I can call a friendship, at least, to something I could label a friendship. And the closest thing he seems to have to that is his house manager. But if a more genuine relationship could be developed, it might help him some.
Yeah.
So I didn't mean to interrupt you, though. We've got a few minutes left.
No. Well, I think that's about it. That's where we are now. I'm starting to do 3-a-week one-on-one sessions with Tony, and then are working to transition him back into the group model. Honestly, I met with him yesterday and told him that we're about 2 weeks out for him joining a group and being a part of a group, which he said, great, okay. So that's our trajectory with him, but hoping to see more progress and work to get everyone who's sort of his circle of support all on the same page of what is the pathway for him. But yeah, that's kind of our snapshot of the program and a snapshot of a person's interaction with our program. So
I love it, and I love that, you know, I think you put some legs on the skill system with what you have put together here. One of the things I particularly liked is how you have really focused on goal setting for the new me activities. I think that's such an important piece of making this all work, is getting a person some goals that they can work on. I'm going to take just a minute here and open it up to the group that's out there. Has anybody submitted any questions through the chat box? If anybody would like to unmute and ask a question, we can have a couple of questions right now. Anybody out there have a question?
Anybody?
Hi, Johnny and Holly. This is Katie Klaus. I'm a ISD. I'm wondering how you're funded.
Yeah, we're funded through MCOs. Our first funding was through United, and then now we're also credentialed through Blue Care.
So it's just a covered service under.
Yes.
With the either.
It's a separate service directly under intensive outpatient programming.
Yes.
Intensive outpatient, yeah.
Yeah.
Great question, Katie. Glad you came in and asked that.
Thanks.
Anybody else out there? Well, Johnny, Holly, I just want to tell you how much I appreciate you guys coming on today and telling us all about this program. It sounds like a great program, one that is right in line with everything that we're trying to accomplish here in Tennessee. And I think you have really put, as I said, put some legs on, put some body with this approach. And so I'm very pleased to hear about that, and I hope that others will hear this and replicate it. And we do this every Tuesday at 12:30. We didn't do it last Tuesday. We are going to reschedule Brad Turner, our commissioner, at some point, the IDD commissioner, to come back on the Clinical Consultation Network. We had a little bit of a snafu last week because of the tornadoes, but we're going to get him rescheduled sometime soon. Again, thank you, Johnny and Holly, for being here with us today, and be with us here every week on the Clinical Consultation Network, 12:30 Central Time and on Tuesdays. So see you next week, folks.
Thanks.
Thanks so much, y'all.
Bye-bye.